Oh, here. Okay. Yeah. Okay, so yeah, I'll just get started. So my name is Ethan Ferris. I'm a fourth year med student here at Baylor College of Medicine down in Houston, and my project was about substance use in people who fall along that sort of spectrum of having some borderline traits or meet the full diagnosis. I was kind of inspired by some clinical encounters I had with patients on the inpatient units that I had worked on like through like electives and my rotations and whatnot. People who had borderline traits or maybe were meeting the diagnosis and it wasn't really crucial to their treatment in the inpatient unit, but it was just like interesting that a lot of times I would talk to people that would have these traits and they would talk about marijuana and just like how cannabis was like super important to them. And it was just like this like recurring theme. And I talked to my attendees about it. I was like, I feel like people who fall along the spectrum, there's like an affinity with marijuana or just cannabis in general, maybe like a self-medicating sort of thing. And they were like, yeah, like it's really interesting. So I mean, like eventually I ended up on this research elective where I was the Menninger Clinic, and I had access to their like huge database where they would do all this like battery of tests like every couple of weeks for all the patients that were on their inpatient, and then follow them up for a few months after exiting the unit. And I just wanted to look at like their substance use rates as well as their borderline traits. So basically, the project I just like looked at their database. I looked at their SCID results, the standardized clinical interview for the DSM-5, and I basically just had two things that I tested: the WHO Assist score, which was looking at their substance use rate at a bunch of different things. We had tobacco, alcohol, cocaine, etc. And then I kind of grouped that with their SCID score for BPD traits, and I kind of looked at the correlation there. And the results showed that there was definitely a relationship between the level of substance use across all these different substances. We had, like I said, amphetamines, hallucinogens, opioids, etc. And there was a relationship there between the level of substance use along these different substances, as well as the sort of level of BPD, like the number of traits, I guess, that they flagged for. So there's definitely like a relation. There was definitely a relationship there. So there was some limitations to the study. I mean, there was not like a normal distribution for any of the data, so I had to use some kind of wacky statistics to be able to like find what the relationship was. The Kruskal-Wallis test. I don't know if anyone's gone down the statistics hole, but it's very complicated. I had to spend a lot of time looking on YouTube videos of how to use SPSS. So but yeah, I mean there was definitely a relationship there. I wasn't able to like but I guess the point is I wasn't really able to like, what's the word, control for other factors, but I'd be curious to see in the future what the relationship was between this level of BPD traits and the level of substance use, controlling for the other substances. So I guess there's definitely an affinity for substance use in general, but I really want to know about specific substances, and like if you control for tobacco, alcohol, etc., is there still a relationship between the traits and cannabis or cocaine or what have you? Because I think that there's clearly a relationship between substance use in general and BPD traits, but I would be curious to see if there was one with specific substances when controlling for other substances. So yeah, I mean that's pretty much it. Just wanted to look at that. It's kind of inspired by some things I saw in the inpatient units, and yeah, definitely was a clear relationship there. So I think there's a lot, just this is just me kind of speculating, but I think there's definitely something to think about. Maybe there's the impulsivity issue, there's the self-medicating issue. I mean, there's a lot of different reasons there might be behind this relationship, but I think just talking to patients with borderline traits, if you're detecting that or if they have a previous diagnosis, important to get that substance use history and make sure you are aware of what what their habits are in terms of that, because there's definitely a significant relationship there between if they have those traits and potentially having a history of substance use disorder, or just generally higher rate of substance use than sort of the average population. So that's pretty much it for me. Short and sweet, but yeah, I hope you guys enjoyed. Yeah. Let me stop sharing my screen. There we go. Okay, gotcha. Yeah.
Thank you so much for your presentation, Ethan. I wanted to open up the floor for questions. You can unmute or you can put them in the chat. Either way works.
Ethan, could you kind of explain the chart, like that triangular chart on your poster? I had trouble understanding it.
For sure. Yeah, this is I was a little confused because I got this nice setup from the people at the Menninger Clinic in the research department, and they had all these posters around the office that had these like lovely posters and these little charts and triangles. And I was like, oh my gosh, this is so cool. And then they showed me kind of how they did it. But basically it was just a sort of a pairwise comparison. So I basically broke down the population into having 0 borderline traits, having some borderline traits, and meeting the full criteria for borderline personality disorder. So those are the 3 groupings. And then I compared them sort of what's the significance of the relationship between each one of those categories and their WHO assist score, which was the scoring system that was used for testing their level of substance use. And the WHO assist breaks down into each substance individually, and then also there's a total score, which is sort of just like I think it's over 50, you kind of meet a criteria for using a lot of substances, right? So basically the triangle was just those 3 groupings of some traits, no traits, or full criteria for BPD, and then their significance for their WHO assist total score. So just like general substance use scoring. And so like the triangle was sort of like, what is the significance of the relationship between those 2 scores? And there was a relationship, I guess, wanted to compare them pairwise, right? So, comparing the yes, they meet the full criteria versus they have traits, full criteria versus no traits, and no traits versus partial criteria. So each one of those comparisons I wanted to make in terms of like, is there a significant difference in terms of their substance use score? So, and there was, so like along that whole spectrum, I guess. And that's kind of one of the main things, I guess, I wanted to take away from this study was like thinking about borderline as a spectrum as opposed to just like a kind of a binary, because you talk to a lot of people and they have some traits, they're not like full-fledged, right? And it's like, is there a relationship along that spectrum as opposed to just they have borderline, they don't have borderline, do they use more substances, yes or no? And yeah, so that triangle was sort of wanting to compare each one of those points. Like it would have been nice because of the data was kind of messy to be able to use it as like a correlation, but I had to use a different statistical test to be able to test it. But yeah, anyway, so just kind of going off topic on a tangent here, but the triangle, yes, that was the pairwise comparisons between traits, no traits, and full criteria.
I just wanted to share a general comment. I think this is really important research because I think in borderline, just specifically, anything that we can do for harm reduction is really wonderful, really great to be able to do that. And I think this shows that, substance use is one of the ways that maybe we can intervene even if they're not ready for DBT. And I like that you said that you already have a future direction for research looking at specific substances, whether it's, substance dependent or if there's kind of this interconnected relationship. So I kind of just wanted to give that positive feedback that I think it's really important research. But
yeah, thank you so much. Yeah, I couldn't agree with more. I mean, if you talk to people with these traits or if they meet the full criteria, it's so striking, speaking with someone, it's like that's the whole like countertransference kind of debriefing conversation that you want to have with your team after you talk to people with these traits, because you're like, this person was just like, oh my gosh, like they I can see why they're burning their bridges with their family, friends, support system, because this is like, I don't know, like, I mean, you know, everyone has their different sort of countertransferential reactions, but I think the average one is like, this person is irritating me, oh my gosh. And it's like, you know, it's like this sort of like the splitting, the, you know, the black and white thinking is like this, it's like this very distinct sort of like type of personality, right? And it's like, these people are suffering so much because it's like you think about it and you're like, okay, I'm going to be the person that is going to be the one to, you know, stop. I'm going to kind of provide that unconditional positive regard, right? And I'm going to be that kind of stable point in their life that it's going to be someone that is not going to take their the behavior, the impulsivity, everything, and react negatively. I'm going to stay very stable and provide that sort of point. And that's, you know, that's, I guess that sort of provides the jumping off point for something like DBT. But it's like, you know, one of these things where it's like we have to think about you know, we can't just be so focused on the borderline traits and trying to get to the point of those, because they have a host of other kinds of issues that might be going on, the substance use, for example. And I think that the substance use, addressing that through counseling or you know, like motivational interviewing or whatever, can be, it can be an obstacle to get to those sorts of things when the borderline traits might be kind of getting in the way, whether it's on your end with the countertransferential reaction or it's on their end with just like kind of putting up a wall. So yeah, I completely agree. I think it's really interesting, and I just think this patient population is really fascinating to me, and I really am interested in it. So thank you. Yeah.
Any other questions for Ethan? So I think that all of the presenters for our next presentation are here. So I think if all of y'all are okay with it, we can move to the next presentation if anyone wants to share their screen.
Yeah, I can share my screen. One sec. Sorry, I have to allow Zoom to. Wait, let's see. This worked. Can you see my screen?
Yes.
Okay, awesome.
All right. Well, good morning, everyone. My name is Marina Yamada.
My name is Megan Schrage.
Hi, everyone. I'm Brittany Quinn.
I'm Sophie Zachary.
And we're all second-year students at Rocky Vista University College of Osteopathic Medicine on the Colorado campus. And today we'll be talking to you about xylazine usage and awareness among people who use drugs in the Denver metro area. So for those of you who don't know, xylazine, also known as tranq, is an alpha-2 adrenergic agonist that was originally developed as an antihypertensive agent, but was never approved for human use. It was later approved as a veterinary sedative, but has recently become increasingly present in the illicit drug supply. Its various effects include central nervous system depression, muscle relaxation, analgesia, respiratory depression, sedation, and vasoconstriction. And vasoconstriction at the site of xylazine injection can lead to increased infection risk and cause skin necrosis and ulcers, which worsen with repeated injection into the wound. And this picture here is from a case study in Philadelphia. And so you can kind of see what the necrosis can look like. Because xylazine is not an opioid, its effects alone cannot be reversed with naloxone, and there are currently no xylazine reversal agents that are approved for human use. Although there is limited information regarding xylazine's pharmacokinetics, studies have shown it has a rapid metabolism and elimination in the body, which can lead to a quick onset of toxic effects. And xylazine's concurrent usage with other illicit substances is also complicating the treatment for patients because it has been found to produce physical dependence and contribute to substance use disorders. Xylazine has also unfortunately been involved in drug-facilitated crimes such as sexual assault in children. The emergence of xylazine is thought to be compensating for the displacement of heroin from the opioid supply and is being used as a less fatal approach to make drugs cheaper and longer lasting. Those that preferably use xylazine mixed with fentanyl claim the fentanyl provides the rush, while xylazine prolongs the high that would normally be short with fentanyl. Although xylazine has been shown to be less fatal than fentanyl, its use has been involved in overdose deaths. Xylazine has become increasingly prevalent in the unregulated drug supply in the United States, most notably in Philadelphia and in other parts of the East Coast. However, despite this, xylazine has become increasingly prevalent across the United States. And as of March of this year, xylazine has been reported in 48 states. It's evident that xylazine is complicating the opioid crisis in the United States. Many healthcare providers are also unaware of xylazine's potential contributions to patient symptoms, and healthcare facilities often do not have the proper equipment to test for its presence. And therefore, assessing the prevalence and motivations of xylazine use is vital for improving harm reduction efforts. Because data about xylazine presence is limited in Colorado, the objective of the study was to understand xylazine awareness and usage among people who use drugs in the Denver metro area. And we hypothesized that awareness of xylazine was limited, that xylazine usage was unintentional, and that the usage of xylazine would be associated with fentanyl use.
Okay, so for methods, this project was done in collaboration with Harm Reduction Action Center in Denver, Colorado. This is a public health agency that works with people who use drugs and gives them access to resources, clean supplies, fentanyl, xylazine testing strips, and then also free Narcan. We all volunteered at Harm Reduction Action Center, so that's kind of how we got introduced to this organization. It is the largest syringe access center in the Denver metro area, so they do have a lot of participants. So we administered a 16-question survey to 148 participants during Harm Reduction Action Center's walk-in hours on weekday mornings from July to August of 2023. The survey was administered on paper and took about 5 to 10 minutes to complete, and the participants were given candy for their participation. The survey was completely anonymous and voluntary. The survey included demographic information, drug of choice, route of drug usage, awareness of xylazine, usage of xylazine, and if that usage was intentional or non-intentional, and then as well as if they had used xylazine testing strips. Responses that were contradictory or blank were excluded from our analysis, and then a chi-square test was performed to determine the level of significance between the 4 most selected drugs of choice: fentanyl, heroin, meth, and THC, and xylazine usage. For this analysis, responses yes and unsure to the question, have you ever used xylazine, were combined to compare against those that responded no. This was done to analyze the significance of those who had never used xylazine compared to those who had used xylazine or were unsure. So our results showed that out of 148 participants, 53% of them had heard of xylazine, while about 42% had not, and 5% were unsure if they had heard of it. The results for this question are shown on figure 2 on our poster, with green being yes, that they had heard of xylazine, blue being no, that they had not heard of xylazine, and yellow being unsure. Xylazine was used knowingly by 16.3% of participants, while 66% of participants said that they had not used xylazine, and 17.7% of participants said that they were unsure if they had used xylazine. The results for this question are shown in figure 3, with green showing that those that had used it, yellow being unsure, and blue representing no xylazine usage. Out of the participants that said they had used it or were unsure if they had used xylazine, 75% said that it was unintentional use, and then this is shown in figure 4 with the same scheme: yellow being unsure, green being yes, and blue being no. 83% of participants reported that they had never used xylazine testing strips, and then 14% said they had. None of those surveyed selected xylazine as their primary drug of choice. The 4 most selected primary drugs of choice were fentanyl, heroin, meth, and THC. Figure 6 shows the complete distribution of primary drug of choice, with the drugs listed on the right side of the chart. Those who selected fentanyl or heroin as their primary drug of choice were significantly more likely to have used xylazine than those who had selected meth or THC as their primary drug of choice. This is shown in figure 7 with the primary drug of choice being on the x-axis, and those that said they had used xylazine in blue, and then those who had not used xylazine in orange.
Sorry, I'm not used to sharing my screen. So in conclusion, we found that, well, as we mentioned earlier, xylazine usage has greatly increased in the United States. And along with this increase in xylazine usage, there's been also an increase in the presence of xylazine overdose cases and deaths since 2020. And our study showed that just under half of the participants in the study had not heard of xylazine, and the majority of the participants that we surveyed had never used xylazine testing strips. So the Harm Reduction Action Center in Denver, as well as the Colorado Department of Public Health and Environment, are working to expand access to xylazine and fentanyl testing strips, but the use of these testing strips still remains pretty low. And we think this could be due to the lack of awareness surrounding the presence of xylazine in the drug supply. And it's possible that the benefits of using xylazine testing strips on drugs are not known to the community of people who do use drugs. So our study found that participants with the primary drug of choice of fentanyl or heroin were significantly more likely to have used xylazine. And this is consistent with several other studies that we found in our literature review finding resources, including Holt et al. 2023. So previous studies have found that xylazine is often added to fentanyl and other opioid drugs to prolong the characteristically short high of opioids. And xylazine doesn't give the same rush as opioids do, which could explain why xylazine is being increasingly laced in opioids. None of the participants in this study indicated that xylazine was their primary drug of choice, indicating that xylazine use was largely unintentional. So harm reduction and public health agencies should focus on spreading awareness of xylazine, its adverse effects, as well as continuing to use naloxone in suspected xylazine overdose cases because it's so commonly found in fentanyl, as well as the benefits of xylazine testing strips to drug users in the Denver metro area. And like mentioned earlier, this is especially important for those who are using fentanyl or heroin.
So, being that xylazine has only recently increased in prevalence in the drug supply, there is very limited research surrounding it and its effects, which leaves many possible avenues available for future research. Most directly relating to our study, xylazine presence could be assessed throughout the state of Colorado to compare its presence in the state as a whole to that of Denver. Based on one of our limitations, which Sophie pointed out, we also believe a strong next step would be to assess the drug supply directly rather than relying on self-reported data. While there is some data on the metabolism and elimination of the drug, pharmacokinetic data regarding different methods of administration are lacking. This data is really important to obtain because people who use drugs use a variety of different routes of administration, such as injecting or smoking. Since there is currently no treatment protocol for xylazine-involved overdoses, studies also should be done to assess possible treatments for this and looking at multi-drug overdoses and withdrawals. Research in this area is lacking and is really needed to effectively treat overdoses that involve the use of xylazine, especially because, as we know, naloxone does not reverse the effects of xylazine. And then finally, we recommend that future studies should examine clinician knowledge surrounding xylazine because it is fairly limited at the moment. And overall, raising awareness about xylazine and its effects will be pivotal in not only helping people who use drugs make more informed medical choices for themselves, but also in reducing the rates of overdose, sexual assault, and other drug-related tragedies, not only in the Denver community here, but in communities throughout the rest of the United States as well. Thank you all for listening.
Thank you so much for that presentation. I'm in Portland and we luckily don't have a lot of xylazine here yet. So I'm very thankful to learn more about it in this presentation. If anybody has questions, feel free to put them in the chat, unmute, direct message me, whatever you prefer.
Thank you. I have a quick question. Thank you so much for the presentation. I really am unfamiliar with xylazine, and I was just wondering, like, you kind of touched on it earlier, but what is kind of like the I don't know how to phrase this. What is like what's the fun of xylazine? Like, why do people take it? Like, what do people get out of that? Like, I mean, I guess you kind of touched on it earlier, like something about the rush of the fentanyl and stuff. Like, could you go over that one more time? Just because I'm curious, like, 'cause I'm like, I don't really know what the like. I'd never heard of this before your presentation and stuff, but it sounds like it's something people use. I mean, so
Yeah, of course. So it prolongs the high, so it's commonly not intentional, as there are some people that desire it, and the ones that do, they say that it prolongs the high. And so when it's laced with fentanyl, people say that the fentanyl provides the rush and xylazine kind of makes it has legs, is what they say.
right.
But
Okay.
overall, it's not necessarily intentional because it can knock you out for days. And one of the other terms that have been used to describe xylazine is it kind of makes you look like a zombie. So if you've ever seen any footage from people in Philadelphia, especially, that's where it's especially prevalent right now. People can be knocked out for days on end. So some people do seek it out, but oftentimes it's not sought out.
Okay, interesting. Yeah, thank you for going over that. I just I've seen those videos of people in Philadelphia who were just like literally zombified. It's crazy. It's like such a I didn't know that was xylazine. I mean, that's really interesting that the kind of prolongs the high, I guess, of the fentanyl. So thank you. Yeah, I appreciate it.
I have two questions. My first one is, why do you think it started in Philadelphia? I know that wasn't exactly your research, but just if any of you knew about maybe the history of like how it got here, that would kind of be interesting to know. And then I have another totally unrelated question.
Yeah, so it was first found to be used. So it was approved as a veterinary tranquilizer. So it's used for that, but it was started to show up in the drug supply in the 2000s in Puerto Rico. And so that probably like that with just being on the same side, that's probably how it started on the East Coast. But yeah, it's definitely been making its way over slowly, but that's probably why the East Coast was hit first by it.
And then my second question is about the skin necrosis. So just from like a clinician harm reduction perspective, does the skin necrosis, like how quickly does that happen? I guess I also just don't know a lot about necrosis clinically yet, but is there a point in which we could intervene and say, hey, individual, I see this is happening, let's have a talk about xylazine? Or does it usually not come up until it gets to like where that picture was, where it's pretty severe?
So often, obviously, with this population, seeking medical care is not something that people do as quickly as someone else that might seek healthcare earlier. And so usually, I don't know the exact timing on how long it would get to that point, but often care is delayed with this population, which makes it look as extreme as it does. From what we saw, which often leads to amputation, unfortunately, just with the amount of necrosis that is present on those wounds. But skin grafts can be used to kind of replace the skin that has like died, basically. But I'm not sure exactly how long it would take to get to that level of severity. But
The case study
yeah,
did say, I think it was a matter of like months, like he had just not gotten medical attention. And it just like speeds along the process of the necrosis or the wound. So like it's probably infected as well. And the necrosis is just, or the vasoconstriction of sites, it's just speeding along that process. Sorry, I didn't mean to interrupt you.
you're good.
To add to that too, It's important to note with xylazine that the skin necrosis doesn't just happen from injecting. It can also happen if you smoke the drug or use other routes of administration, because it's an alpha-2 adrenergic agonist. So it's part of the mechanism of the drug to vasoconstrict. So you can see the necrosis in any route of administration of xylazine.
Sophie, I really like that you mentioned that, because I'm on my clinical rotations, and it is really great that I've seen a lot of physicians ask, what is the route of administration? But I think it would be really easy to make the assumption that people are only going to get necrosis if they're, IV injecting. So I think that's a really important distinction, and also something we can look at to how we actually educate clinicians, so they know to still counsel on that potential of necrosis, irrespective of the actual form of use. Any other questions? I think we have a few more minutes until our next presentation. We can also take a quick break, or just have a chat about anything in general too. We can pause recording and just chat. I don't think Josh is here yet, who's our next presenter. So why don't we just do that? I'm gonna pause. So I think our next presenter just arrived. Josh, if you want to start sharing your screen, I made you co-host.
Okay, give me one moment.
Also, Josh and I will be presenting together. I know my name's not on there, but hi, I'm Kate.
Okay, there we go. Can
Okay,
everybody hear us okay?
Yes.
All right.
So I'll do the first little bit. I'm Kate and this is Josh, and we're going to be presenting on a case report for substance use disorder treated with ketamine-assisted psychotherapy and a 12-step program. So this is just an overview of kind of what we'll be going through today. So a little introduction. Substance use disorders are highly prevalent and very difficult to treat, as I'm sure we all know, given the subject of this conference. So the mainstay of treatments include community-based 12-step programs, psychosocial interventions like IOPs, and then also pharmacological interventions like methadone and naltrexone. However, the effectiveness of these interventions is limited, and there is room for improvement. So, next slide. So, in particular, this patient that we're going to be talking about in a little bit has a polysubstance use disorder, and so we were interested in kind of getting a little bit of a background on how ketamine has been used in many different types of substance use disorders. So in particular with cocaine use disorder, ketamine infusions reduced amount and frequency of cocaine use in a 3-arm crossover design randomized control trial. Additionally, ketamine infusions reduced cocaine self-administration rates and cravings in a 2-arm crossover design randomized control trial. Additionally, opioid use disorder has been effectively treated with ketamine infusions as well. And this 1- and 2-year abstinence rates were higher in opioid use disorder patients who received a single high-dose ketamine treatment compared to a single low dose in a 2-arm randomized controlled trial. Additionally, patients who received a 1 high-dose ketamine treatment and a bi-monthly ketamine-assisted psychotherapy session had higher rates of abstinence than patients who received 1 high-dose ketamine treatment and a bi-monthly general addiction counseling sessions. So kind of this combination of care has a lot of potential. As it relates to alcohol use disorder, total abstinence rates at 1 year were higher in patients who underwent a single ketamine treatment combined with existential-oriented psychotherapy compared to patients who received treatment as usual, so just kind of your mainstay treatment. And then another study, a single ketamine infusion increased abstinence, delayed relapse, and reduced heavy drinking compared to midazolam. So ketamine and substance use disorders. So as you can see, ketamine has demonstrated early promise for treating substance use disorder showing reductions in use and other associated symptoms. However, what's kind of novel about the case we're presenting today is a combination of a few different treatment modalities. So integrating ketamine-assisted psychotherapy with existing psychological, psychosocial, and community-based treatment paradigms. So in particular, the report we're presenting today gives details on practical methods of combining psychedelic ketamine-based treatment regimens with psychosocial and 12-step based treatments for substance use disorder. One thing that we found particularly interesting and exciting about this case was the interclinic collaboration between these kind of 3 separate entities working together to kind of meet the needs of this individual. So there's collaboration between an outpatient ketamine clinic and a 12-step IOP. And the relationship between the psychotherapists, the ketamine-assisted psychotherapy and IV ketamine infusion team, plus the 12-step IOP team was managed by the therapist and the directors of the different clinics. So they were in communication throughout the treatment. Just a little bit about our case here. This case is 28-year-old female, and she had polysubstance use disorder. She also had some other psychological diagnoses, or psychiatric diagnoses rather, listed here. And then she was on some medications during her treatment as well. And to note, she did have some past psychiatric inpatient admissions for substance use, rehabilitation, and suicidal ideation.
Okay, thanks, Kate. And so I'll kind of take the baton from here. My name is Dr. Joshua Willms. I have a PhD in pharmacology and neuroscience with an emphasis on addiction. And I'm a third-year medical student. So our understanding of the practical implementation of psychotherapy, of 12-step programs, of traditional modalities for addiction is very, very, very well established. Psychotherapy has been around for decades and decades. 12-step programs, decades and decades. They've been tried, they've been tested, there's training programs. What's come up that's very new is ketamine-assisted psychotherapy, as well as ketamine infusions. And so I assume that kind of most of the audience isn't well versed on those yet, so I'll just talk a bit about how those things are done. So ketamine is a psychedelic compound that can place a patient into sort of, if there's normal consciousness, which everybody understands and experiences, and then there's dreaming when you're asleep. which kind of everybody understands and experiences. When somebody is in a low dose ketamine infusion, they're in sort of a not awake, not dreaming, kind of in a off on the Z axis of what's possible in consciousness. And when a person is in that space, probably what most people have heard about from that is from drug abuse or from recreational drug use, when actually there's a huge potential for a clinical use for that state of consciousness. And a person will kind of be in a place where they can look at things in their life and change their mind. They can reframe traumatic things that happened in the past. They may even be more receptive to psychotherapeutic approaches. And so what we wanted to do with this case report is we know that ketamine infusions and ketamine-assisted psychotherapy can be very effective for substance use disorders, or at least we're starting to see the research come out on that. But if that's the case, then in a practical sense, how do we combine that with the modalities that we've used for a long time? So for this patient, the first stage was a preparation phase. You never want to take somebody and throw them into a psychedelic treatment without coaching, without preparation, without orientation. It'd be very much like sending somebody to a foreign country. They just wash up on the seashore. They don't speak the language. They don't know where they are. And then expecting them to go on, a life-changing backpacking trip or something like that. They're more likely to get lost or be disoriented. If they have some orientation, or even better, they have a guide there to help them navigate this very new space, then they're far more likely to benefit from that experience. So in ketamine-assisted psychotherapy, there's a guide there with the person who's right next to them. Depending on the dose, they can even talk back and forth. So the first step for this patient was, an intensive screening, make sure that there isn't danger to the patient, make sure that there aren't medical contraindications. Start out with standard psychotherapy to develop a relationship, to educate, and then do a single ketamine-assisted psychotherapy session. This lasts about 2 hours, and about 45 minutes of that is within a ketamine space. And by that, I mean they get an IM shot of a low dose ketamine. And then for about 45 minutes, they're in a sort of a lucid dream-like state, but still generally able to have a conversation and be guided by the therapist. And then a single IKI, which is isolated ketamine infusion, where there's a higher dose in an IV bag. So in the infusion, they can, if they need to, they can stop it. But the patient goes into a deeper experience with that because of the higher dose. And so because of that, it's generally not possible for a therapist to really intervene or have a conversation. So after sort of establishing rapport, getting a relationship with the patient, educating, starting out with psychotherapy, a single ketamine-assisted psychotherapy session, and a single ketamine infusion, the patient underwent a 12-step intensive outpatient program. And so for many of these programs, they want patients to be entirely sober, not on anything, fully sober, and there's accountability, so they're going to ask you, and there's an expectation of being fully honest. And so for this patient to be fully honest, they would have to talk about, I'm actually kind of a combined program here. And so many 12-step programs would probably be heavily against a patient undergoing psychedelic therapy around or in conjunction with a 12-step program. But based on the research that we're seeing, that psychedelic therapy can be very effective for substance use disorders, this 12-step program was open to working with the ketamine clinic as well as that outside therapist, to set the patient up, kind of to get them ready for the 12-step with psychedelic medicine. During the 12-step outpatient experience, there were no psychedelic treatments. It was just full immersion in the 12-step. So that's the traditional, the 12-step meetings, the weekly individual psychotherapy, options for family therapy, and then also psychoeducation sessions. And then once that was completed, the patient did 2 ketamine-assisted psychotherapy sessions and 4 ketamine infusions. Then after that, the patient moved into a maintenance phase. One of the acknowledged potential problems with, say, with intensive outpatient treatment, or especially with an inpatient treatment paradigm, is that patients will do well while they're there, but then when they leave that environment, they are more likely to lose the progress that they've made. So instead of going from full treatment, getting them all the support they can get, to nothing and they're out on their own, we expanded out to a maintenance phase where treatments were spaced out at longer intervals. And I'll just show that. This is a summary of the whole paradigm. So at the beginning, preparation, getting the patient ready, which did include psychedelic therapy. Then the intensive treatments with the 12-step intensive outpatient program, as well as the psychoeducation, as well as behavioral interventions, like yoga. And then after that, there was 1 month with 2 ketamine-assisted psychotherapy sessions and 4 ketamine infusions, as well as 2 integration sessions. And then after that, the maintenance phase. So overall, the point of this report wasn't to attempt to collect data on, kind of add to the evidence we already have on, is this approach effective or not? We have some studies ongoing right now that are actually attempting to do that. But in the meantime, we already know that ketamine and psychedelic medical interventions can be very effective for substance use disorders, including cocaine use disorder, alcohol use disorder, opiate use disorder, and potentially smoking, and potentially a few others. And since we are starting to see that, it's time, hopefully, to try to integrate these new treatments in with the vast infrastructure that's already in place, with 12-step programs, outpatient treatment programs, and potentially in the future, maybe even inpatient treatment programs. And so what we were trying to do is give an idea of practically how could someone start to try to integrate those multiple paradigms to hopefully get the best outcome for a patient. So this is sort of a pilot, just a case report on how this was done in 1 patient, and hopefully in the future we'll be able to share further data on the studies that we have going with this. So thank you very much. Are there any questions? Okay, we got a question here. Okay, do you think there could ever be studies on this treatment paradigm that incorporate brain PET scans or fMRI to track neurobiological changes associated with the treatment? Yes, and this has been done. If you wanted me to send some of those, just message me your email. Just shoot me an email and I can share some of those studies. But yes, this has been done. There's been ketamine is a very old drug. It's been used at much higher doses for surgery for a long time, for a very, very long time. So it's been very well studied. The safety has been very well established. So it's new for psychiatry, but it's not new to medicine. So there's been tons of studies like you talked about. Yeah, good question. Any other questions? Okay, well, thank you very much. If anybody does have any other questions, please feel free to shoot me an email. And I appreciate everybody's time.
Thank you so much for your presentation. It was really interesting. I think ketamine definitely has a lot of treatment potential, so I appreciate you doing a case report on that. So I think our next speaker is here, Daniel. Let's see, or maybe Daniel's here. Daniel, whenever you're ready to share your screen, you are welcome to get started with your presentation.
Everyone, yeah, just setting up the presentation here. Just a second.
No worries, we're running a few minutes early, so no rush.
All right. Is it full screen for you guys?
No, it is it's like a minimized screen and it's not in presenter mode, but maybe okay, there we go.
There we go. Okay. All right, everyone. Well, pleasure to be here. I'm Daniel. I'm a recent graduate from Brazil. I'm part of a research group in technological interventions for substance use disorders. Here, this small meta-analysis was conducted by Anderson, Fernanda, myself, Gabriel, and our mentor Anand, Dr. Anand from the Cleveland Clinic in Ohio. Our meta-analysis here is a work of research trying to understand the impacts of an internet-based CBT. So it's a cognitive behavioral therapy developed to address some limitations in treatment due to in-person treatment. So access management, basically, for alcohol use disorder. So let's start by introducing the problem. Alcohol use disorder is a very, very huge problem, as we all know. This is a major health concern worldwide. One of the biggest problems is it's ubiquitous, so you find it everywhere. We're all gonna treat patients with alcohol use disorder, whether we pursue psychiatry or not. It's a huge problem all over the world. One of the biggest problems, particularly in alcohol use disorder, is the treatment gap. So there's a whole bunch of patients that need treatment that can't get the treatment they need, whether due to stigma or lack of access actually to treatment. There are a whole bunch of variables included in that. But one of the problems that can be solved is access, at least in some sense. And the idea of this kind of treatment, internet-based CBT, is to explore this access problem. The idea that, well, we can try and find cheaper solutions, more flexible solutions, versatile solutions for patients that actually need more treatment, more, how would I say, more time with the provider, or more time thinking about the disease, more time thinking about their problem and the solutions. So a more treatment time in a cost-effective way. So ICBT came as this sort of solution. It comes in several forms. But the one we evaluated in this meta-analysis was a self-guided ICBT. That means the patient is gonna be doing the treatment himself. There's a sort of a manual, there's a sort of a program with homework the patient needs to go through, but it's going to be self-paced. The patient decides how quickly he wants to do it, how often. There's a schedule, but you can do it like whenever you can. You don't need to schedule an appointment with a provider and just hope it's going to be all right, commute, all that. One of the greatest advantages is the cost, right? So it's scalable. Whenever you do it once, it's basically free to reproduce in terms of the provider of the solution. Well, some patients also value the privacy aspect, the anonymity aspect. You don't need to go to a place to seek treatment and risk meeting people there you didn't want to see you, and things like that. Well, the problem obviously is the lack of human connection, and it's one of the most basic aspects of all therapies. Well, all therapies have that in common. It's a relationship with another human who's actually actively trying to listen to you and actively trying to help. That's a common feature among all of the therapies, but not for ICBT. So this is the part that's isolated and we don't have you there as long as it's completely self-guided. And our idea here was to do a very focused, very specific meta-analysis of only randomized controlled trials, comparing the self-guided only mode of ICBT to standard face-to-face CBT for specifically alcohol use disorder. So we did a standard literature review this year in August. And one of the challenges that I'd like to just point out to you guys is we did it very specifically. Several of the trials for ICBT did not use alcohol use disorder as a diagnosis per se. Lots of them used other criteria such as audit score to include the populations. Several of them used multiple sources, multiple groups as both as treatment groups and as control groups. There wasn't like a very standardized way of conducting those clinical trials. Another challenge we did face was the fact that outcomes were presented in various amounts, in various forms, in various types of numbers. So there was not a standardized outcome that every single RCT provided. So we did have those challenges in order to conduct this final meta-analysis study. So that's why we have this Prisma flow that started with so many papers screened. We only were able to include, after everything, only 3 actually RCTs. So 3 eligible RCTs, 387 participants among all of them. 2 of them followed up for 3 months and the other one for only 2 months. And the only outcome they all shared we could analyze was the alcohol-free days. So we couldn't do a single outcome for all of them in terms of amount of alcohol consumed or something like that. Those are the details of the studies. This is a more clear picture of our findings. So for those 3 studies, the RCTs we could include in our meta-analysis, they showed non-inferiority, right? Which is a interesting finding for us, considering all the limitations in terms of treatment without a person there. Considering it was self-guided. So it's not clear that it's inferior. It seems like it works, at least in this preliminary analysis of those trials. It does support keep pursuing the analysis of more clinical trials for this kind of treatment, for this modality of treatment, which is really interesting. I think other things that are really interesting to discuss about this is more about the treatment itself. So the study is quite simple, so there's not that much to talk about specifically our meta-analysis. But my main goal here, talking to you guys, is just to kind of evangelize and bring the idea that there are digital treatments that can be useful for many of our patients. For this meta-analysis itself, we did do it only self-paced. We did it without a therapist involved, but there are several other studies using this modality of treatment, showing that it works great as an add-on as well. It works great when there's a therapist monitoring the patient. So the patient goes, see the therapist, they talk before, and then the treatment is conducted online, completely virtually, and then the patient comes back to the person that did the initial evaluation. It all works. Most of the studies we have seen, they all work somehow. So sometimes they include different populations with less severe features of the diagnosis. So not all of them would fit the bill for alcohol use disorder, but just harmful alcohol use, for example. And whatever way we would see in the literature, this treatment would be useful. And it would decrease the amount of days as long as the patient would actually complete the treatment. So sometimes in some RCTs, if you were to be analyzed in intention to treat analysis, sometimes it wouldn't work. But whenever it was per protocol, it would be clear that the effects of the digital intervention would be great and useful and would benefit the patients. So I think my main goal here is just to bring this modality of treatment to your mind, just so you remember this exists. If you didn't know that, just know that it exists. Know that you can just find something like this for your patients. Sometimes maybe you can advocate to find treatments like those. In terms of cost, the most widely available treatment and most studied treatment, the CBT for CBT, it's the brand name for this modality of treatment. It was initially developed for cocaine addiction, but it's also used for alcohol use disorder. So cocaine use disorder, but also alcohol use disorder. This is around $100 per patient for the full 7 weeks treatment. The treatment is basically the same ideas that we have to teach the patients during in-person CBT. So the treatment includes lots of work on coping mechanisms, trying to work on other ways to communicate with people without the context of using substances. So relationship management, so coping, reward systems. So the treatment would assist the patient in finding other rewarding behaviors. The treatment will also assist in avoiding the, how do you say this word? Sorry about that. Craving. So this is a sort of ideas included in the treatment. And I just wanted to share with you all that this is a treatment that exists. It seems that it works even in strict conditions such as alcohol use disorder per se, not only harmful alcohol use. It's easily available, it's scalable, reproducible. You can use it as an add-on, you can use it exclusively, whatever fits the bill for each patient. We can customize care and do the best we can with whole bunch of tools we have available for our patients. I think that was my main goal here with this presentation. And with this, I'm open to questions if anybody has some.
Thank you so much for your presentation, Daniel. Yeah, I think it's super important that we really investigate different kinds of just options for patients. I know access to in-person treatment, especially like post-discharge from detox, is really hard to find sometimes, especially for people in rural areas, or when people have to work strange hours or just work 10 hours a day. So I think this is really important research, and important that we continue to investigate different options for patients.
Sure. Thanks for your comment. That'll be it.
So I think our next speaker is here and ready. Xenia, I made you co-host if you are ready to share.
Thank you. Is that showing up all right?
Yes.
Perfect. Should I start, or should I wait a few minutes to go ahead?
Either way, you can go ahead and start, or you can wait. It's recorded too, so if anybody misses a few minutes of it, they can always go back and look if they want to.
All right, yeah, I'll start. Okay, so hi everybody, my name is Xenia. I'm a third-year medical student at Mayo Clinic Alex School of Medicine. And here today I'll be presenting on the effects of an elective week at a substance use treatment center on the attitudes of medical students towards substance use and individuals with substance use. So as a bit of background, individuals with substance use disorders face an overwhelming amount of stigma for their disease from society at large and healthcare professionals alike. Individuals with substance use disorders are seen to be more violent, manipulative, and more non-compliant than other patients by healthcare professionals. And these negative attitudes may make it more difficult for patients to admit to their substance use disorders or their substance use in general to their main healthcare provider, as well as to participate and to actually buy into treatment programs. Healthcare professionals that don't specialize in substance use disorders often, through surveys, report that they feel less comfortable assessing for and treating substance use, despite substance use actually being quite a prevalent disorder affecting a significant amount of the US population. In 2021, the National Survey on Drug Use and Health reported that 16.5% of the US population had a substance use disorder, which is quite a staggering amount. It's about a fifth. But because of the high prevalence of substance use disorders and the general discomfort of treatment of substance use disorders among healthcare professionals, early introduction, education, and experience with substance use for medical trainees can improve future care for individuals with substance use disorders. Hazelden Betty Ford is a Minnesota-based addiction treatment and advocacy organization. They have a campus in Minnesota and have a campus in California. Has a myriad of educational initiatives and has a graduate school. They also have this week-long program for medical students that are interested in a hands-on experience to learn more about addiction medicine while being in a kind of top-notch addiction center. And Hazelden started partnering with Mayo Clinic School of Medicine in February of 2022. And with the help of funding from the Hazelden Betty Ford Foundation, interested students like myself and several others could travel to either the Minnesota or California Hazelden campus for 1 week to participate in this educational program. Briefly, the program included things like lectures on biopsychosocial models of addiction, included direct participation in patient treatment groups and treatment programs, There was direct learning from patients through shadowing of a patient or through just participating in the patient's day-to-day activities, and then open discussions about addiction treatment with center staff. So in 2023, we had 30 students from our medical school participate in this program, total 31st and second year students. Those 30, 14 willingly participated in completing a pre and post program survey to assess their attitudes towards individuals with substance use disorders. You can see their demographic breakdown on the right. So we ended up administering the brief substance abuse attitude survey, or the BSAS, to these 14 students before and after the completion of the program. This is a modification of the just regular substance abuse attitude survey, and is 25 Likert scale questions versus the original, which was 50. But we figured that was a bit lengthy for our purposes. But this questionnaire targets 5 main attitude domains. The first being non-moralism. Non-moralism assesses one's degree of moralistic attitudes towards those who use substances. So an example of a question that targets this is alcoholism is associated with a weak will, which implies kind of a moralistic attitude to individuals that use alcohol. The next domain is treatment optimism. Treatment optimism assesses one's attitudes that display an optimistic awareness of early intervention and treatment outcomes for individuals with substance use. So a statement that one might use to assess this is an alcohol or drug dependent person cannot be helped until he or she has hit rock bottom. The next domain is non-stereotypes. This assesses the degree of reliance on stereotypes and societal views of substance use to form your attitudes of individuals with substance use. So an example of a statement that people might use to assess this is heroin is so addicting that no one can really recover once he or she becomes an addict. Treatment intervention is the next one. This assesses one's alignment with the current standards of substance use treatment, or at least at the time of creation of the survey, the standards of substance use treatment. One of the example statements is physicians who diagnose alcoholism early improve the chance of treatment success. And then finally, the last one is permissiveness, and this assesses one's degree of acceptance towards substance use within the range of normal societal behaviors. So, for example, daily use of one marijuana cigarette is not necessarily harmful, and people would strongly agree to agree, strongly disagree to strongly agree with that statement. So, after our students took this survey before and after participating in this week-long program, we saw an increase in treatment optimism from students, as well as an increase in agreements with statements on treatment intervention and an increase in non-moralism generally. And I'll go through kind of more specific examples of these results in future slides. So the next couple slides are going to be on statements regarding treatment optimism. So that's that attitude that displays an optimistic awareness of early intervention of treatment outcomes. So for this statement, an alcohol or drug addicted person who has relapsed several times really cannot be treated. Students were more likely to strongly disagree with this statement after completing our program. Students were more likely to strongly agree with the statement drug addiction is a treatable illness after completing our program. And we're more likely to strongly disagree with the statement that most alcohol and drug dependent persons are unpleasant to work with as patients. Sorry, this actually gets into our non-moralism category now, or treatment intervention program category. More students were likely to agree with the statement paraprofessional counselors can provide effective treatment for a drug and alcohol abuser. And more students were likely to agree with the statement that group therapy is very important in the treatment of alcoholism or drug addiction. Physicians who diagnose alcoholism early improve the chance of treatment success. Students were more likely to strongly agree with the statement after completion of the program. this is now getting into our non-moralism category. So students were more likely to strongly disagree with the statement that alcoholism is associated with a weak will. And I think this is one of our strongest relationships that we found, which is really encouraging. This is one of the more interesting results, but students were, generally speaking, more likely to disagree with the statement a nurse who is drug dependent should not be allowed to give medications to patients. I think it's interesting because it's the most extreme change. So a lot of students agreed with the statement before the program, and then the prevailing amount disagreed or strongly disagreed, and then the indecision was also kind of elevated. And then this is the next couple of statements are in regards to attitudes toward Alcoholics Anonymous specifically as a program. So active participation in a program such as AA is essential for a patient to recover from alcohol or drug dependence. More students strongly agreed with this statement after completing the program. And the last one, a recovering person who is active in Alcoholics Anonymous does not respond well to psychotherapy. More students strongly disagreed with the statement after completing the program. So in sum, after completing this 1 week program, students were more likely to support Alcoholics Anonymous through the results of these statements that we saw. So in general, after completing this program, we saw that students were more likely to agree with statements that supported current treatment practices in substance use, such as Alcoholics Anonymous and group therapy. And group therapy was a big part of what students saw at Hazelden and participated in at Hazelden, which makes sense. And then students were also less likely to agree with statements that implied bias against individuals with substance use disorders. These results were really encouraging to us. First, they show that the program is rather effective in its primary goal of reducing bias and exposing students, medical students specifically, to individuals with substance use disorders. They show that even a short 1 week long educational program that does these things, that exposes students to individuals with substance use in a humanizing and compassionate manner, and in the setting of willing participation in treatment, which is often not what we see on our clinical rotations, can significantly reduce pre-existing biases that people might have held. And it also shows that it can clarify assumptions about addiction medicine and substance use treatment that students can hold from a variety of sources. And the incorporation of education on substance use treatment in medical school curriculums varies significantly, and it is generally not very high, but an implementation of similar short programs and 1 week long programs at other schools could improve future care of individuals with substance use disorders on a national level. And as far as future directions, we would like to expand this program to kind of an increased amount of students possible. We ended up sending, I think, a total of 3 cohorts, 3 to 5 cohorts, and some of them went to the Minnesota campus and some of them went to California campus. And then recently we've run out of funding, so we're hoping to A, renew our funding, and B, increase the program so that more students are able to go. And just based on the feedback we've received verbally after completion of this program, students love this program and find it incredibly impactful. And when I went as a first year medical student, it was one of the most impactful things I've done in medical school to date. So we would love to continue to provide a similar opportunity to other students, and knowing the effectiveness of this, hopefully expand it to our kind of local resources. It doesn't have to be such a relatively inaccessible travel week-long period, but we can engage our local substance use treatment resources that we have in creating kind of a similar educational program. So yeah, with that, I'll open up to
Thank you so much for your presentation. I actually did the SIMS program in, I think it was 2022 at the Oregon campus.
oh, nice.
So Yeah, totally agree that it was a very transformative experience. And then the change in the answers. I remember doing those surveys and definitely had similar change in my cohort as well. Yeah, but I am super supportive of the work Hazelden is doing. And so this is more of just a logistical question. So do you know if Sims is happening this coming up year? Because I think you mentioned a funding issue.
Yeah, so can you still hear me? I don't know if my mic is
Mm-hmm.
okay. I know that our program, like the partnership with Mayo, has lapsed. And I tried to look up the Sims program for like this coming year, and I think that their website's down. So I don't know if that implies that they're not having it anymore, which would be a
Yeah.
huge bummer. But yeah, I'm not sure. I don't know if they've had like a change in like organization of this program or
Mm-hmm.
leadership or something, but yeah.
Yeah, I also looked it up because I was talking about it yesterday. We had two people actually from Hazelden on a recovery panel, and I was trying to
Mhm.
link the Sims program and I couldn't find it, and I felt really bad because I got people
Yeah.
excited about it. So I guess a question I have for you is thinking about how effective Hazelden's program is.
Yeah.
I was wondering what your thoughts are on how we can maybe translate that into medical school education, because the people that go to Hazelden are already motivated to learn about
Yeah.
substance use and addiction. But I was thinking maybe the people that can almost most benefit from it are the people that maybe aren't as open. And so I was wondering if you think there's potential to kind of modify it, condense it so it could be a part of medical school.
Yeah, I was thinking about this as well. So I was thinking about, so for us anyways, during our psychiatry rotation, we are required to go to a Alcoholics Anonymous meeting, like an open meeting. And I think that's a lot of people's first exposure to something like that, like in third year of medical school, which is too late. I mean, it's earlier than a lot of people get, I guess, but it is still too late. So I think doing something similar to that, like there's so many open AA meetings, and I think going to one, even like in first year as a part of I don't know, like a school's extracurricular curriculum, or depending on the school, like how they structure that, I think would do a lot. And I think going to even one or a few meetings, I think is really eye-opening for a lot of people. And it's just like something they've never been exposed to before. They've never thought to like conceptualize individuals with substance use disorders as these kind of human beings. And then going to a meeting and hearing people's personal stories is very moving for the majority of people that I know. And yeah, I think that was one of the biggest things that I've thought about. But yeah, as someone said in the chat, there's a lot of open meetings. So there's closed meetings, of course, where people are not allowed to visit, or it's just allowed for individuals with an alcohol use disorder. But for example, like where I live in Rochester, Minnesota, you can literally Google open AA meetings Rochester, Minnesota, and you will see a list of them. And you can go there. They are held weekly. There's several of them weekly, and you can go. And if we just like disseminate that information to first years, second years, I think it's a very easy, like it's an hour, it's a very easy and it's a very impactful experience. Beyond that, I think there's a lot of good to be seen in incorporating substance use treatment material into just general pre-clerkship didactic material, which I don't think a lot of people do, but because it's so, I mean, it's a disease that's prevalent in every single patient population. So therefore, in my mind, it should be, at least a part of a course for like neurology and cardiology and like all of these systems that are affected by substance use, at least on a very like basal medical level. So those are the thoughts that I've had. But I know that this is kind of massive undertaking to remake medical school curriculums in general. So yeah, willing to hear any other suggestions or any other thoughts that you have.
Yeah, I'm totally on the same page. My medical school actually used to require that every student went to an AA meeting, but they don't anymore, which is really interesting that they used to do something that was very beneficial and they no longer do that. And something else that I've heard, which is very interesting, is, you know, why some people that are in the curriculum department don't want to increase substance use education is because there's other quote unquote more board relevant material. But, you know, from my experience having taken Comlex and Step 1 and then COMATS, which is kind of like the DO shelf, it's actually super prevalent now.
It is. It's totally on the shelf. Yeah.
So it's kind of an interesting okay, I don't want to see the word excuse, but an interesting explanation for maybe why they don't want to increase the mandatory education and kind of say, okay, well, that can be extracurricular. But, you know, as we're seeing with our generation, there's a lot more interest in it. And as people like us start to have positions where we're actually in, you know, really having an effect on the curriculum, maybe through leadership positions at medical schools, etc. Hopefully that's going to change. Because right now it's slow moving, which is frustrating, but
yeah, I'm with you. I think that the way that we started thinking about our substance use curriculum at our school was that one of my colleagues noticed that almost all of like the slides and educational material that we've received about any substance use like uses kind of really outdated language, like substance abusers or like the alcoholics or like, you know, like things like this that we're kind of trying to push away from. And we had a meeting with one of our DEI chairs about like looking into this and how can we change this, and she was basically like, it's not up to us. You know, there's like so many people to maneuver in. But yeah, I agree with you. I'm hopeful for future generation.
So I don't think our next presenter is here yet. So I'm going to pause the recording so anyone that has been on for a while can take a bathroom break, get food, water, etc.
Hi, can everyone hear me?
Yes.
Okay, great. Sorry, I thought the presentation started at 1:40, so I'm just confirming that everything is good.
Yes, definitely. We're just running a little early, so
Okay.
we can, yeah, no worries.
No worries. Okay, great. I can start. So, hi everyone. Thank you for this opportunity. My name is Amulia Valipoli, and I'm a second-year medical student at Medical College of Georgia. And today I'll be presenting on the rising popularity of synthetic cannabinoids and the risk of psychotic disorders. So delta-8 THC was legalized under the Agricultural Improvement Act of 2018, also known as the Farm Bill. And it legalized the usage of delta-8 THC for those over the age of 21 in US, and it was sanctioned by the FDA, the Federal Drug Administration. Delta-8 THC is definitely not a prescription drug. So we want to look into the use of cannabis and how it is a known risk factor for psychotic disorders, including schizophrenia. And we were exploring the rising popularity of delta-8 THC and other synthetic cannabinoids in comparison to cannabis and other naturally occurring THC compounds. So what we wanted to do was mitigate the risk of psychosis and the development of schizophrenia, as delta-8 THC and other synthetic cannabinoids are now widely available and easily accessible substances. So what we did was we conducted a... Oh, sorry.
No, it's okay. I started sharing my screen because I think yours wasn't loaded yet. So
Okay.
I had your presentation, so I just went ahead and shared it. I hope that's okay. Sorry.
No, that's great. Thank you so much. I didn't even realize I was just going.
That's okay.
I was so nervous.
I have it up now.
Awesome. Thank you, Priscilla. But I hope everyone caught on to what I was talking about just now. So now I'm going to be talking about the methods and what we use to help our search. So what we did was a Google Trends analysis using the terms delta-8 THC, delta-9 THC, cannabis, psychosis, and schizophrenia between the time periods of 2017 and 2023. And then we looked into different subregions, looking for search outputs by states. And then we did a systematic literature review using PubMed to look up the terms cannabis, delta-8 THC, delta-9 THC, psychosis, and schizophrenia. So as we can see on the graph, if we maybe zoomed in a little bit, but it's like tiny font there. But what we can see in the first graph is that the search term for delta-8 THC had a significant rise in 2021. And then also we can see in the second graph that there is a concurrent increase in both delta-8 THC and the search term psychosis. And what we can sort of look into this about around that time frame is that 5 states in 2021 and around 2022, early 2022, legalized the usage of cannabis. Some of those states include Connecticut, New Jersey, Virginia, New Mexico, and New York. And if we zoom back out a little bit, going to the results section, so the searches for delta-8 THC and delta-9 THC have significantly risen in the past 5 years, with a 400% increase in search term popularity between July 2022 and August 2023. And the search term psychosis experienced a concurrent peak, as we saw in the second graph, in January 2022, with a very similar subregion profile of being near the southern states area, especially with those without legal non-prescription cannabis, and there was also a similar rise in the search terms for delta-8 THC and delta-9 THC in those particular states, those states being Tennessee, Georgia, and Alabama. So from our literature review, we found out that delta-8 THC has a partial agonist activity at the cannabinoid CB1 receptor and possesses a cannabimimetic activity. So it creates similar somatic symptoms, similar psychic effects, and similar many very similar actions towards the way that natural delta-9 THC works. And because the usage of delta-8 THC in many cannabinoid products is very low, FDA doesn't really regulate those levels as much. And also they don't really regulate what is being put into those compounds and how those compounds are being made. So the risk for these psychotic disorders that could be induced by these synthetic cannabinoids really needs to be looked into further and needs to be researched, because we don't really know as much about them. Going into the discussion portion. So the legalization of synthetic cannabinoids really implores the need for further evaluation of the psychiatric effects that could be caused by these synthetic versions of the natural compound. The popularity of searches has really risen in the past 5 years. So that means that a lot more people are really interested in knowing more about what they're consuming and the effects of what they're consuming. People are really curious to understand what is going on into the products that they're using, how it impacts them, and what are sort of like the side effects of using these drugs. And because delta-8 THC is very similar chemically as like naturally occurring THC compounds, which are also known as delta-9 THC compounds, and they have a partial agonist activity at the CB1 receptor, there's a large sort of like, if we look at a Venn diagram, there's a large area where both of them kind of connect, of the kind of psychosis inducing effects that could occur. And the implications of legalization of cannabinoids really impacts how mental health providers and healthcare workers assess the risk of certain psychotic disorders and how they approach the treatment of those disorders. And furthermore, the FDA has issued several warnings against using cannabinoids and creating large amounts of information or trying to create awareness for consumers who are using cannabinoids and synthetic cannabinoids, but they're not able to regulate the products themselves because they're being labeled as a Delta 9. They're not being labeled as Delta 9 THC, which is the one that is specifically marketed as not usable by consumers. But they're both all cannabinoid products are known as a class 1 drug, so you can't prescribe that drug without creating a lot of signatures and like involving a lot of documentation before you are able to prescribe that drug. And by being aware of the legality, risk profile, and activity of cannabinoids, providers have better insight into the impact it may have on their patients. Thank you.
Thank you so much for your presentation. If anybody has questions, feel free to put them in the chat or you can unmute.
Hi, so I've read studies on some like cannabis-induced psychoses and how compared to like, you know, primary psychoses diagnosed in psych patients, they tend to have a bit more of a manic picture than just primary psychoses. And I was wondering if that's a similar thing when it's inducing psychoses by synthetic cannabinoids.
Yeah, that's a great question, Ramona. Thank you for that question. So what I've read so far has shown that Delta 8 THC and Delta 9 THC, which is the natural occurring THC, compounds have very similar risk profiles of inducing like psychosis or psychosis-related disorders. There's I think the most common thing that I've seen so far in my I haven't read all literature on this stuff, but the most common thing I've seen is that the psychic effects of Delta 8 THC are slightly reduced compared to Delta 9 THC. And it's just like a slightly lesser euphoria as compared to Delta 9 THC, but the somatic and perceptual effects are about the same. So you still see the same like dizziness, dryness of mucous membranes, like paresthesia, tinnitus, like all these other like similar somatic effects are still the same. And the perceptual effects of like blurring of vibration, distortions of vision, altered perspectives, those are about the same. It's just the psychic effects that I've seen are slightly more diminished as compared to Delta 9 THC, which is the natural version of the compound. But if you have any research that could lead the other way, I'd like to know more too. Thanks, Ramona.
Thank you for clarifying that, and thanks for your presentation.
No, thank you. Hi, Cecilia.
Hi. I was just wondering if you noticed between the different forms of THC, if there was a difference in worsening of catatonic symptoms of psychosis?
I don't think I've looked into that as much, but I could look into it for future reference. That's a great question. I just don't know.
Thank you.
Thank you.
Well, I think our next presenters are here. If you all want to share your presentation, we can go ahead and get started. And thank you so much, Amelia.
Hi, I think I'm presenting next, but I'm trying to figure out how to share my screen because it's two of us, Chelsea and I, presenting together. So,
And I can also share the presentation too if you're having issues pulling it up.
I have it open, but I don't know.
I can share it if everybody's okay with that.
Yes, please.
Okay, awesome. Okay.
Okay, perfect. Everybody can see it?
Yes.
Okay,
Okay.
awesome.
Okay, is that okay if I start or?
Yeah, go ahead, Julia.
Okay. All right. So, hi, my name is Julia McCann, and Chelsea and I are OMS2 students at Kansas Com in Wichita, and we will be presenting a case report on treatment outcomes of Suboxone versus alternative medications for fentanyl use disorder. So in this case report, we will talk about the patient's medical and treatment history concerning his fentanyl usage, as well as we discuss the outcomes of each treatment administered. We will also expand upon the efficacy of each treatment provided to the patient, and we will particularly focus on Suboxone in management of his withdrawal symptoms. And before I talk about the case, I wanted to give a little bit of background on the opioid use disorder and some medications that I used. So according to National Center of Drug Abuse Statistics, the opioid use disorder affects 2.7 million people in America, which is about 1% of the population of the age of 12 and older. Currently, there are several medications approved for treatment of opioid use disorder, and some of them are used as monotherapy, and some are used as a combination of, for example, in medication assisted treatment. Some examples of the medications are buprenorphine, which is a partial opioid agonist, methadone, which is a full opioid agonist, and naltrexone, which is an opioid antagonist. But again, Chelsea will expand on those medications a little bit more. Here, I'm just giving a little brief overview. So there is a high chance of the patient opioid misuse or withdrawal symptoms with those medications. So recently there are a few medications came out on the market, and Suboxone is one of them. It is a combination medication, and it includes buprenorphine and naloxone as active ingredients, which can provide advantages in the long-term management of opioid use disorder. So managing opioid use disorder is not a simple task. There are a lot of things to consider when picking an optimal treatment for opioid use disorder, such as like the length of opioid use disorder, comorbidities of the patient, or the severity of dependency. So it takes a lot for the provider to make the right decision. So in our case, we have a 21-year-old healthy Caucasian male with an active fentanyl use disorder. He presents to the clinic with active withdrawal symptoms, including diaphoresis, malaise, abdominal cramps, diarrhea, and he admitted that his last fentanyl use was the morning of the clinic visit. So the patient also admits that he was hospitalized previously at the drug rehab center for 3 weeks, where he was given 2 milligrams of buprenorphine once daily, as well as he received naltrexone injections at the previous clinic visits. However, the patient discontinued those treatments due to increase of severity of his withdrawal symptoms. The patient also admitted to being prescribed 2 milligrams per day of Suboxone in the past, which did not work for him. So he discontinued that medication as well. So at the clinic, Dr. Seiler prescribed the patient Suboxone 8 milligrams twice daily. And interestingly, the patient started to feel relief about 2 to 3 hours after taking his first dose. And at his 1 month follow-up appointment, patient did not report having any withdrawal symptoms or any other adverse effects of Suboxone, which was pretty good. So yeah, that was a little overview of the case. And now Chelsea will talk more about the advantages and disadvantages of each medication. And she will also talk about conclusion and discussion. Thank you so much.
Awesome. Thank you so much, Julia. So again, I'm just going to go over the different treatments that the patient received in his prior medical history, as well as what he's being administered. So buprenorphine, like Julia said before, is a partial opioid agonist, which means it could activate opioid receptors to a lesser extent than full agonists. And it is primarily monotherapy in various forms, such as injectables, sublingual film, or tablets for opioid dependence or moderate to severe pain. Some of the advantages are that it could lower the withdrawal symptoms and cravings without producing similar euphoria levels as full opioids, which is part of the ceiling effect from it being a partial opioid agonist. And one disadvantage is that it has the possibility of being diverted or misused, which may lead to an elevated risk of dependence. So naltrexone is an opioid receptor antagonist, which means it's going to bind to the opioid receptors. However, it's not going to activate it. Rather, it's just going to curb the euphoric and sedative effects that are associated with opioids. It's administered as a monthly extended release injection, also known as Vivitrol, or daily. It could also be administered as a daily oral tablet for individuals. Because it is an opioid receptor antagonist, there are no addictive properties. There's no risk of diversion or misuse. And one unique thing about naltrexone is that patients have to undergo a period of opioid abstinence with no indication of opioid dependence at all prior to being given this medication. Otherwise, if patients were to be given naltrexone and still have opioids in their system, that may increase withdrawal symptoms. Suboxone is a combination medication, which is composed of both buprenorphine, which is, again, a partial opioid agonist, and naloxone, which is also another opioid receptor antagonist. It's administered as a sublingual film treatment for opioid dependence. And the advantages of it are that it decreases withdrawal symptoms and cravings, and it lowers the risk of misuse compared to buprenorphine alone. However, there is still that possible risk of misuse and dependence. It's just not as much compared to buprenorphine alone. So for the conclusion, overall, we just wanted this case study to underscore the efficacy of Suboxone as an optimal treatment option for lowering the withdrawal symptoms and cravings for fentanyl compared to buprenorphine alone or naltrexone. And the combination of buprenorphine and naloxone and Suboxone addresses the withdrawal symptoms by activating those opioid receptors to a lesser extent and discouraging misuse through the antagonistic action of naloxone. And the patient's positive response to Suboxone, as evidenced by the absence of reported withdrawal symptoms or cravings, it contrasts with the potential challenges if treated with buprenorphine alone, where aggravated symptoms may lead to discontinuation. And in choosing naltrexone over Suboxone, that poses the risk of worsening withdrawal symptoms as well, as the patient needs to be fully detoxified from opioids for at least 7 to 14 days. And also naltrexone does not adequately address the cravings. And in removing the data waiver requirement for buprenorphine prescription, healthcare providers now have more freedom in being able to give buprenorphine-based medications like Suboxone, especially to a larger number of individuals with opioid use disorder. And hopefully this change could just overall increase the accessibility and availability of these medications and mitigate the expanding opioid epidemic across the US. And that's it. Thank you so much, everyone, for attending this presentation. I know you guys are very busy, whether it's with rotations or board studying or just life in general. So thank you so much for attending. And now we're going to open it up to questions if anybody has any.
Thank you so much for your presentation. I was recently on one of my psychiatry rotations, and it was really interesting to see how many providers were knowledgeable about buprenorphine and also just patient interest in it, or maybe lack of interest in it if they kind of heard about precipitated withdrawal. One of the patients that was not really interested in getting on buprenorphine while in the hospital was because one of his primary care providers had actually given him buprenorphine, but then I guess they weren't as knowledgeable about it. And then so the patient had precipitated withdrawal, and it was just a really bad experience. So how do you think we can go about maybe providing more education for primary care physicians about how to correctly use these medications? Because with the data waiver being removed, there's a lack of a barrier, but it still seems there's lack of education, if that makes sense. So I was just wondering if either of you had any thoughts about that.
So I do know I guess with my school specifically, I am part of the opioid prevention committee. So I am in the process of trying to expand on addiction medicine curriculum in our school, and just being able to provide that not only in like didactics, but also rotations. And I do know that there is some sort of training that you would have to undergo, like even with the data waiver being removed. I think if you're trying to like renew your DA or whatever that may be, I think you have to have like a total of 8 hours of training from like certain organizations on opioid or other substance use disorders. So I think hopefully with that, we could still be educated even more on that. That is a very good question, Priscilla. I'm so glad you asked that. I honestly, I just only know like what we could do right now. But again, it's like it's easier to say it than to actually like do it and hope for the best, you know? So, and Julia, if you have like any comments on that.
Yeah, just like you said, Chelsea, everything starts in the early training of providers, especially PCP, like Priscilla noticed. So just like being in a new school and being medical students, having connections to the outside, to the community, providing training to medical students would be like one step to eliminating that problem. And that's exactly what you're doing, Chelsea. Thank you for that. I don't know, we haven't had a training on Suboxone specifically, but we did have training on naloxone as medical students, which is pretty amazing. So I think just doing that, and maybe, we also have physicians from all over the state coming and visiting our medical school and just talking to them, telling them about like doing presentations like we did at KOM last week. So just spreading awareness. That's all we can do for now. Once we become physicians, I guess we will have more power. But for now, it's just spreading and letting people know.
Yeah, I definitely think that providing more education early on, especially in medical school, is 100% the best way to go about, just having providers actually be more knowledgeable about medication-assisted treatment. And also just, the work y'all were doing with this presentation, and everyone that's attending this conference, and, getting more education and knowledge, which is really going to help patients. And yeah. Any other questions? Or sorry, Chelsea, do you have something you wanted to say?
Oh, no. I was just going to say, like you said it perfectly. Just because I think it's so important for people to understand that it's not like a one medication fits all type of treatment. Like you do have to analyze like not only like who they are, but like their history, their risk of misuse, what they're wanting from their treatment. Because I know with this patient specifically, he received naltrexone injections, but he wasn't detoxified like prior to receiving those injections. And he also did not receive psychosocial support that's supposed to be associated with that. So I think it's very important for providers, especially nowadays, to realize that it's not just about giving them medications. It's about making sure like they have medication-assisted treatment with a whole comprehensive treatment plan, for sure.
So if there are not any more questions, this is actually our final presentation. Jayla is unfortunately not able to make it to her presentation today. So if there's no more questions, anything else, then I guess this wraps up day 2 of the PsychSIGN Addiction Psychiatry Conference. And thank you to everyone that's attended.